Okay, I wanted to do just a quick recap so that everybody can have their mind gathered and sort of oriented to where we are in our overall time together on case formulation and treatment planning. So here's what we've done. Okay, so we started with case formulation and treatment planning for stage 1, focused on fidelity. And the basic idea, just right here, is that people who have a history of biological vulnerability to emotion dysregulation, plus grow up or experience extremely invalidating or pervasively invalidating environments, end up with a common set of skills deficits and patterns of regulating emotion and other behavior that have unintended consequences, that it's the best they can do with an extremely difficult kind of combination of factors, and they've come by it honestly, but it ends up not working for them in the long run. And so the quickest way to resolve that, help somebody really make some progress, is to identify the common links across the top targets. So using the target hierarchy, say, for just an example, do chain analyses and look across, say, instances of suicide attempts, instances of non-suicidal self-injury, look at some of the factors that have led to treatment dropout in the past. And then across those, what you'll see are commonalities. And the idea is if you can zoom in and focus with building up skills and alternative behaviors that would really help in those exact moments, you'll be more likely to get change across these targets, okay? And so just for an example, it may be that if you looked across this set of instances over time and across targets, what you might find is it's really dysregulation of shame after an interpersonal rejection that gets the person into trouble. And if you could get them so that they had less of the cue, so they were better in relationships, they were more tolerant of interpersonal rejection, and they could manage shame more skillfully, you could really make progress across the crowd. So this idea of fidelity and doing a case formulation that's kind of by the book, it's a way of demonstrating that you know the treatment, that you are fluid with its interventions, that you can think from the model, the basic model. And so like if you're going for certification or something like that, or you have some other reason why you need to put it all together, that's a case formulation and a treatment plan. But where we've been working is more on the mini treatment plans. In other words, it's at this common link level that if you really hone in and identify where that is, that's the level where you're more working session by session and trying to make the decisions like, right here, do I go more for acceptance or more for change? Or is this more someplace I should do skills training, or is this more of an informal exposure or formal exposure type of moment? So it's the kind of mini nitty-gritty case formulation that we've emphasized, because it's the whole idea of case formulation is that it should work for you. It should help you guide your treatment plan. Okay, and now we're on lack of progress. And one of the basic things that I've been trying to get across is lack of progress is a fact. Doesn't mean you're doing it wrong, doesn't mean your patient's doing it wrong. It's that change is super difficult, especially when you have complicated problems. And that, very smart people, including the patient, have tried for a long time to get to change. So lack of progress is just a circumstance that requires you to have the skills with case formulation and treatment planning that you know how to solve, how to work your way out of the stuck spot. So the set of things that we've been working on here is first providing you with a chance to think. For many of you, if you had a chance to think, you would be fine. Like that's really all it is. You just have to get your thoughts together. And I provided for you this list from Jackie Persons. It's just a very useful list as a first place of sort of pass of thinking, okay, why are we stuck? Why is this not going differently? Could be something about the poor therapeutic alliance, low readiness to change. Then this set all have to do with treatment plan, that it's unclear or unshared, that it's inadequate, that it's not fully implemented. Then there's problems with the actual formulation, that it's either absent or faulty, that you just don't quite have what is up with the person. And then there's a set of things that are, I think of as just you get in there and then you figure it out. So diagnostic errors, that substance misuse is having a bigger problem, or that the extreme lack of social support is really a rate limiting factor, okay? So just scanning these, often if you pause, you scan, you see where it is, you get a few ideas and you give those a try and off you go. Sometimes, and this is where I like to work a fair amount, what's needed is that you really, in a systematic way, put yourself through a conceptualization of both the patient, but also of your own gaps. So these questions apply as much to why is this patient stuck as well as why am I stuck, okay? So the first is, are both of us clear on the problem and clear on the task? What are we working on? Do we understand it? Are we clear about what we should do about it? If the answer is no, then that's where you work. If you are, then you say, okay, are we both motivated? This gets a little bit to low readiness to change, but it also may be your motivation, that it's very hard for you to step in and really get something to go different because you know it's going to be aversive, for example. So are you and the patient motivated to do whatever you're clear is the task? And then third, if you're both clear, you know what's wrong, what to do about it, you're motivated to do it, then what is getting in the way? Is it a skills deficit? Are emotions getting in the way? Some sort of conditioned emotional response? Are contingencies supporting the wrong behavior and not supporting the preferred alternative behavior? Or are there cognitive content beliefs, attitudes, myths, or processes, patterns of being overly rigid or fixed in one's thinking, concrete, etc., that are getting in the way? Okay, so that to me is always a really great place to just run through your paces with these three questions. And then let me just highlight some of the things that we've done around this. I'm saying that often when you're not clear on the problem, when you're stuck, it's really helpful to go deeper into empathy, to imagine yourself being your person, starting their day, going all the way through their day, and really trying to experience what is up for them. That sometimes an increased empathy, being clearer on what exactly is the problem from their perspective, immediately gives you information about what you should be doing different. So that's one, another kind of default. It's like these tools to pick up when you're stuck that help you sort of think your way out. So one is really going deeper into empathy, giving up change for a moment, getting where they're coming from, and seeing if a deeper understanding will let you see how to get out of wherever you're stuck. The other common thing that I've been trying to highlight through the consultations we've done so far is that often people are not as precise as is optimal about what is the alternative behavior you want. So if you get down to, I am working on this specific thing, and then you should be able to describe in a way that the client can nod their head, they get what you mean. What do you want to see instead? What's the very first step? How are you going to cue it? How are you going to reinforce it when it happens? So this level of precision, really slicing thin what you want to see instead, just with the one thing, not the 5 things, but the one thing, is super important, and often that's a really nice place to start to get unstuck. And then the other thing is sometimes our skills are not up to the task, and I just think this is true for everybody. And so sometimes strengthening your competence and fluidity with the model is what's most helpful or needed, and this is why we're coding the tapes. There's nothing like getting to see somebody else handle something. Just the information flowing through your eye, having to label it, can really increase your ability to then do it. So that's kind of, this is where we've been working. And now the other piece that we're working on is there's this preparation. So after you have a time to think, kind of get yourself together, sort it out as best you can, then often you have to discuss it. Like, you need to either discuss it with your patient or you need to discuss it with your team or both. And what I've been pitching is that you work to create a mini case formulation, just that kind of very tight, okay, when this set of cues comes, you tend to respond like this, has these unintended consequences. And so I think if we get that to go, is that right? Head nod. I think if we can get that to go different by pitch the alternative behavior, head nod. And it's actually going to be longer because, and then the change procedures, how we would work on it. So you're really pulling for behavioral rehearsal and kind of more involved courses of treatment, plans for treatment. But you're doing it in a way where the patient is nodding their head, they're collaborating, they're correcting your understanding, they are buying in and help build the treatment plan. And with the consult team, you're getting them out to the edge of your thinking so they don't start generating a bunch of stuff you've already tried or, dragging you off into the bushes because they don't get how you're already, where you've already gone. So being able to ask a clear consultation request so you have a chance to get something useful back is the other step. Okay, so that is where we are. I hope that was helpful just to bring it all together again.